Dr. Vafi, today we would like to talk about this new technique that you and your team initiated. It is called completely diverted tube ileostomy for the protection of colorectal anastomosis. What is it exactly and how it is performed?
Yes, thank you for your question. The tube ileostomy is not a new technique, but it was described about 40 years ago, but it doesn't take its place in our practice, in our daily practice. Up to today, we use conventional ileostomy or colostomy to protect the anastomosis. Since this technique, the tube ileostomy, which was previously described in the literature, has some problems as a technique and function, so it doesn't take its place in the daily practice.
Is it done separately or during or after a colorectal surgery?
Yes, it is one part of the operation. Well, it's as you know, when you perform anastomosis, particularly in lower gastrointestinal tract, as after rectal cancer or rectal resection, when you make the anastomosis, there is a risk which is between 5 to 10% risk of leakage. To prevent the mortality and morbidity related to this risk, we have we do ileostomy or colostomy as a protective method to divert the feces out away from the anastomosis. But the tube ileostomy technique, which was previously described in the literature, has majorly two problems. The first one, the material used in this technique. Different materials were used for performing tube ileostomy, such as chest tubes, Foley catheters, endotracheal tubes. The big problem with these materials is kinking. While you after you insert it inside the abdomen, inside the bowel, it's easily kinking, it's easily obstructed, so it is a big problem of functioning of this tube. The second challenge of this technique is completely diversion. The materials used to complete diversion were tubes with inflated balloon to obstruct the lumen and to achieve complete diversion, but it fails to perform it because the intestine moving around the balloon and diversion was not performed previously. In this technique we described here, we have two solutions for two problems. The first one, we use a tube with spiral reinforcement, so there is no kinking. Inside the tube there is a stainless steel wire spiral to prevent obstruction of the tube. So we are the first who described using this tube in tube ileostomy technique. The second solution of our technique is complete diversion by occluding the lumen of the ileum by rubber band distally to the tube to prevent the feces going distally toward the anastomosis. So when we use this rubber band around the intestine and suspend it into toward the abdominal wall smoothly, without tension, we have a completely diversion as we described in our paper, which was published in Journal of Colorectal Disease, and we have about more than 80 cases we performed in our clinic.
How long does this tube stay in the patient's body and how easy is it to take it out?
From 2 to 3 weeks. It's still for a short time while the patient in hospital. And removing the tube is very easy since there's no any intervention or procedure is needed. You can take out it spontaneously without any intervention. Cut the suture, the fixing of the suture on the skin, and take out as a drain, as anything other.
Does this surgery save the patient from having a colostomy? Will the patient need post-operative colostomy?
Yeah, this is an alternative to colostomy or ileostomy. We talk about protective stoma, protective ileostomy or colostomy. If there is an indication for loop ileostomy or loop colostomy, this is the best alternative to choose.
Which patient cases might be eligible for this procedure? Cancer, non-cancer?
All of cases underwent colorectal surgery and need diversion, protective stoma, are eligible for this technique without exclusion of cancer or non-cancer cases.
How long after the surgery can the defecation process be restored or get back to normal?
After you remove the rubber band, which we usually remove it after 1 week postoperatively, the gases start to pass, and after removing the tube, after 2 weeks of the surgery, stool passes start quickly inside 2 to 3 days.
Is this a common procedure performed in Turkey or Europe? Have you had a chance to present it in international scientific conferences? What acknowledgements have you received so far?
Yes, I have presented it in the European Coloproctology Congress in Germany, in France, 2 years ago. But we have at that time a little cases, so was a poster presentation. Nowadays, we are in pandemic of COVID-19. We have no chance to go outside the country and present it in the congresses.
Thank you.